Well, hello and welcome to all of our viewers around the world. I'm Fiona Langsharp, IBCLC Director of Communications and MC here at Gold. Thank you so much for joining us here today. We are back with Jim Thigpen, who is here, and he's going to be speaking at our upcoming Gold Neonatal Online Conference 2023. It's been a hot minute, Jim, since you were here with us last time, but we're absolutely delighted to have you back. So excited. But, I think it's time that you did a reintroduction, because there's been a few things that have happened in your life since we saw you last time. I'll let you talk about those things, but please, tell folks a little bit about where you are, what you do, and how things are going for you.
Well, thank you, Fiona. It has been a little while since we did this. Let's see, what do I do? Or where I am, I'm in Johnson City, Tennessee. I'm originally from South Carolina, about 300 miles to the south of where I am now, but I've been in Tennessee for 30 years, actually, longer than I ever lived in South Carolina.
Oh, wow.
I came here as the first pediatric pharmacist in a relatively new children's hospital, and have been with them, stayed there for 15 years, and then joined the College of Pharmacy here at East Tennessee State University 15 years ago. So kind of half and half of my time, but my practice site never changed. I still was a clinical pharmacist at the Niswonger Children's Hospital. Currently, we have a 37-bed neonatal ICU. We don't do cardiothoracic surgery. We do everything else, but we're a pretty solid neonatal ICU, and really enjoy. I've always enjoyed rounding in the NICU, and I round on the general peds floor as well as PICU. But the NICU has always held a special place in my heart. So, and you were saying that things have happened different in my life. Yeah. Our oldest son, he and his wife had their first baby, our first grandson, almost a month ago, actually a month ago today.
Oh, wow.
And so he was born at 37 weeks, a little smaller than his dad, but he has really grown, and it was like having a baby all over again without all the responsibility. All the joys and love that you immediately feel when you have a child, but it's your grandchild. It's even better, actually, because you can say, here, you change them. I don't have to. So it's been a lot of fun. I really, and he's thriving. He's nursing well and just growing, and we're really, really enjoying it. So it's been a joy, honestly. So.
That's wonderful. Well, it really is great to have you back, and your dedication to this field of work is just unbelievable. I know that you, one of the hard things, when you're an educator, sometimes it can be hard to teach on this topic, and especially for people who are not, just in the field. But you do such a great job. For us here, and I know for your students, you know how to do that knowledge translation, which is so valuable. The topic that you're speaking on, not the easiest topic, of course. Once again, we didn't want to give you something too easy. Pharmacotherapy for hemodynamic instability in neonates. Jim, is this an area that you knew a lot about before coming in, or did you have to relook at this? Tell me a little bit about kind of the status in this area with you.
I would say the answer to that is both. It's certainly been something that I have worked with a lot over my entire career. What's interesting about neonatology, and I just taught this to my students a few weeks ago. They had my final exam yesterday, and talking about neonatology, and having a perspective of 30 years or longer, actually since 1988, when I first set foot in the Children's Hospital and was taken to the NICU and was like wide-eyed, like everybody is when they first enter that, and have seen the evolution of neonatology over this long. Some things don't change. Ampicillin and gentamicin was the initial drug cocktail, antibiotic cocktail that we used back in at MUSC back in 1988, and it's still the primary, drug therapy that we use for neonatal infection, or at least, initially.
Yeah.
That hasn't changed a bit, and nor has general treatment of neonatal hypotension. We have certainly learned a lot over the years, whereas, we would only use dopamine, and we would rarely use anything else. We didn't use epi, and now when we're likely to use epinephrine, but it's still very slow to change. And it just takes a while it takes a while to study babies for obvious reasons. And it just takes a while for information to be disseminated. And then it takes a while for practitioners to become comfortable
Right.
using something that they haven't used before. And it's just again, that's okay. But I think with, things are developing more rapidly. Information is disseminating more rapidly. We're studying things a little differently than we used to, with different technology and different statistical methods and predictability of things that we didn't do before. And I think the knowledge is accelerating, so that we feel, I think our level of comfort is speeding up. It doesn't take as much time for us to say, let's try something a little differently than we've done before. And along with that, some of the other technologies that we have to measure this objective information that we need to try to make these adjustments that these babies really require, we're getting more scientific with it, and it's also becoming more commonplace. And again, it just takes a while, and again, that's okay. I think when practitioners feel comfortable with something, then they're better at it, and the babies are benefited by that. And then it just takes a while. So it's good to try to get this information out. And for me, at least, it was a review and a little bit of an expansion, if you will, of what I've seen before, because I had never heard of one of the drugs that was being used in this presentation. And then I'd absolutely never heard of something else that we're using now, or at least is being looked at, and we may see in the future. And so those things are always discoveries that are like, hey, wow, I didn't know about this. So, preparing to talk about a topic that, you know a good bit about, but
Sure.
you don't know everything, or you may not do it as much as some people do, because honestly, babies that have, significant congenital heart disease, really the care for those children are oftentimes concentrated in centers, and in other places don't really see those babies very long. And so, and that's the case with my institution. If we have a baby with hypoplastic left heart, we put them on prostaglandin and stabilize them and ship them. As soon as they can go, we ship them. We fly them out, because we can't handle. We don't have the surgical technology, the surgeons to handle those kind of babies. And so it's good for people like us to also be exposed to all this stuff that might not being used with us as often, so that when the time comes that we need to, we're more comfortable doing it, and we have the literature, and we have the research out there that we can go, okay, this is where this has been used, and if we're going to do this is how we need to do it. So this has been a nice review for me as well, to prepare for this. So
I love that. I love that. Well, I feel like you haven't changed a bit. You're such a humble person, and but yet you thrive in this arena of somewhat. I find that it's a hurry up and wait process often with NICU. It's like a lot of patience is needed, in terms of when you've got products that are being reviewed, or if there's trials going on, which are definitely fewer and far between compared to other healthcare fields, because of the nature of babies and fragility and those types of things. But yet there still is good research that comes out, but the translation, of course, getting it into process, I feel too that it has somewhat sped up over the years. I think there's more of a dedicated field of folks that are hungry for change, and just making the environment better overall for these babies that come in, no matter what is going on with them. I have found that that there's a different type of dedication in the NICU, and I see it in you. It's so interesting. You guys are
well, there really is, and students that round with me, my pharmacy students that round with me, we might start out on the general pediatric service, and we'll spend a couple of weeks there, and then we'll transition into the NICU or the PICU and the NICU at the same time. And I've had many students say, yeah, these nurses and the doctors in the neonatal ICU are a little bit different, aren't they? And I said, yes. I said, I told you guys in class that it's neonatology,
Yeah.
Then it's pediatrics, and then it's adult
Yeah.
medicine. I
Yeah.
said, and there, it's a different place.
Yeah,
And
for
it's just,
sure.
it's unique, and the people are so dedicated.
Yeah.
And the nurses, especially that are in the NICU, want to be there,
Totally.
and they are fierce with their babies. And it's just, I don't know. I've always really
It's
liked it. I've always
true.
warned my students, you better not cross that, don't do anything
No.
that'll upset her or that
No.
nurse, because they're gonna get you. Don't do
That's
that.
right.
So
No, those nurses are fierce, and I think that's a really good word for them. And I've had nurses fight for my own child, so I know what it's like, and I've had the pleasure of working in there as a lactation consultant. And so I really appreciate the whole sort of environment and how it's continued to change and evolve. It isn't always perfect, but you know what, there is a real dedication to making sure that this field is recognized in medicine as unique and needs very unique circumstances in order to make sure that the research is there, and we're careful about how we manage all those things. So thank you,
Absolutely.
Jim. I mean, thanks for all. I mean, I know you're educating, and it's such a huge thing to be able to watch these students come up behind us and make sure that they have the tools and the dedication that we want them to have. So thank you again.
Yeah, my pleasure. It's really an honor to I've been very blessed to do what I do for a living.
Yeah, that's
people
wonderful.
ask me about retiring, and I'm nowhere near retirement yet, but it's like, I'm like, it might be kind of hard to give up. It just depends. We'll see.
Yeah. And congratulations again to your newest little one, addition to your family, first grandchild in the family, and cute as a button. So thank you so much, for sharing that with us. We're excited for you, and keep us posted. But to all of our viewers out there, don't forget to check out this important topic with Jim Thigpen, the pharmacotherapy of hemodynamic instability in neonates. We'll look forward to seeing you online. And of course, you can join in on the recorded version of this, and you'll also be able to post questions in the forums for Jim if you have any. So we'll look forward to engaging with you there. Thank you again for joining us here today, Jim. It's been great chatting with you.
It's always good to talk to you, Fiona.
Yeah. And thank you to all of our viewers chiming in today. Don't forget to join us over on goldneonatal.com for all of the latest details. You can register now for the event and catch up with what's happening in our add-on packages, and then of course our main conference. We'll look forward to seeing all of you online. Thank you again for joining us here today, and we'll look forward to seeing you all very soon. Bye-bye for now.